Before we started this trial, there was only one randomized trial that looked at a salvage transplant for relapsed multiple myeloma. And this trial compared against a control arm of a cyclophosphamide-based consolidation, which as of today is not considered a standard treatment anymore. So the question was, how would a salvage transplant compare to a novel agent-based continuous regimen? And from the old study, we knew that there was a significant survival benefit, and that study was performed by the UK colleagues from the UK MRA, led by Dr. Gordon Cook. And our question was, can we replicate this benefit if we compare to a more modern regimen? And so our control arm in the trial was continuous lenalidomide dexamethasone at standard doses until progression of the disease. And in the experimental arm, we had a lenalidomide dexamethasone induction followed by high-dose chemotherapy, stem cell transplantation, and then lenalidomide maintenance until progression. This trial ran at 16 trial sites in Germany and included 282 patients that were randomized into one of two trial arms that I've just described to you. So at data cutoff, which was in 2017, we had a median follow-up time of 36 months. And surprisingly, we did not see a PFS or overall survival benefit in the primary analysis. However, there were certain limitations that make interpretation of this finding difficult. Specifically, there was an increased rate of high-risk cytogenetics in the transplant arm, which is a known risk factor for multiple myeloma. And then there was a substantial fraction of patients in the transplant arm that did not actually receive the transplant. So there were diverse reasons for that, but in about half of those patients that dropped out before the transplant, this was related to early disease progression and led to a total dropout rate before the transplant of about 30%. So the obvious question then was, what would the treatment effect be in those patients that actually did receive the transplant? And to answer that, we performed landmark analysis from the time of the transplant in the transplant arm and from the corresponding time point, which was RD cycle 5 in the control arm. And these landmark analyses showed a significant survival benefit associated, significant overall survival benefit associated with the transplant and a trend towards improved PFS. When we look at this multivariately, including established risk factors, including high-risk cytogenetics, for example, then we do see a significant association of the transplant with both improved PFS as well as overall survival. Yeah, so to answer this question, we performed subgroup analyses that were presented in a separate talk here at ASH this year. And what we found was that patients with low-risk multiple myeloma, so patients with a low revised international staging system score, patients with low risk or standard risk cytogenetics, and patients with a normal LDH had improved PFS as well as overall survival in the trial, and they had excellent survival actually in this low risk subgroup. On the other hand, patients that had high risk features in these categories, these high risk features had a deleterious impact on the treatment effect, so they did not benefit from the transplant. Yeah, obviously that is the important question as of 2018, and I should say up front we cannot directly answer this from our trial because our control arm was RD, so it wasn't a triplet, it was a doublet, if you will. And what we can do is, of course, we can look at the efficacy parameters. Median PFS in our study was 21 months for the transplant patients. If we compare this to the triplet regimens, which is something that you only can do very carefully, but if we do so, then this falls within the range of what we see for the triplets, however, at the lower end of the range. So if we then go back to the subgroup analyses that I've just reported you, then we do think that the salvage transplant still plays a role for patients with standard risk features, low risk multiple myeloma. These are the patients that typically can be treated with one after the other treatment line, and they will keep responding and responding, and they benefit from the additional treatment line of a high-dose therapy and stem cell transplant at ReLApsE. Conversely, patients with high-risk features, we saw that they did not benefit from the transplant. On the other hand, if you look at the triplets, there is also a benefit for high-risk patients from the triplets. And even if this does not abrogate the negative prognostic impact that is associated with high-risk features, it still improves their prognosis. And on top of that, of course, if available, inclusion of such patients into trials to improve their prognosis further in the future, it would be the best option.